Hello, this is Anne Breen, one of the lecturers on the Health and Social Care team up in Ballymena. Today I'm going to be taking you through Learning Outcome 1.3 of the Communication Unit. So Learning Outcome 3 is you need to review different methods to deal with inappropriate behaviour. So who might present inappropriate communication within a health and social care environment? And that can either be, it can be service providers, the social care staff, or indeed it can be service users. So something as simple as maybe a rushed consultation, maybe the fact that they're very stressed, that can be classed as inappropriate communication. Even communicating with someone who doesn't have language as or English as their first language, and the non-provision of means of interpretation, be it an interpreter or signed language or any other means of communication. That indeed would be an inappropriate way to communicate. Service users may communicate inappropriately for various different reasons, and that may be due to underlying conditions such as dementia, or indeed the fact maybe that they can't communicate if they've had a stroke. So I'm going to show you this short YouTube video, and this is a consultation between a nurse and a service user, and indeed this is an example of how communication can be very inappropriate. So I will summarise at the end of this short video clip.
Hi, I'm Hannah. I talked with you, I know, the other day, but I just wanted to touch
Hi,
base today, about your stuff, your situation. So I read your chart, and I know we talked last time. Are you still feeling depressed?
Yeah.
Depression's okay. Depression. And I know you're feeling depressed now, but I felt depressed before, and it will pass. Like, you'll get over it. It's not that big of a deal. And so this depression, why are you feeling depressed?
Well,
Oh, wait, sorry, I had another note. Something else I wanted to ask you before. No, why, or is that depression what brought you in here?
Well, I OD'd earlier
Ooh,
because I was
depressed.
really sad.
Yeah. Okay, so that overdose, we'll have to talk about. So then why are you feeling depressed?
Well, I was abused earlier. I just don't.
I mean, your life
I
doesn't,
do.
I looked in your chart and your life doesn't seem all that bad, so this depression, I think you can get over it. Yeah, let me look at my notes here. I know we saw some stuff. Oh, hey, yeah, can I talk to you later? I'm gonna finish talking to her. Okay. Sorry, I lost my train of thought. Let me look at my notes here. You got the abuse, the overdose. So can we talk about these thoughts? No, that, like, that area. Do you want to, are you still having those thoughts?
No.
No? Okay, then. Great. No thoughts? Because I mean, if you're having them, it's kind of like, why, I don't understand why people think of, like, killing themselves. It's really very weak of them to do. Personally. But anywho's, oh, hold on a second. Hold on. Hello? No, I'm at work right now. Yeah. You know at Belmont? Yeah. I'm going to talk with this patient here. Yeah. And I'll call you back. Okay. Okay. Bye. I'm sorry. Yeah. Anywho, so let me look at my notes. But so you, those thoughts we were saying, what were you saying about those? Did you have them? I forget.
Well, no.
No. Okay, that's great. I'm glad. So are you feeling better then?
I guess a little.
Yeah. So what do you think has worked in your therapy?
I like talking to the therapist.
One-on-one?
Mm-hmm.
Okay. Well, do you want me to see if your doctor's available? I can
Yeah.
totally arrange that. Okay, I'm going to go check that then right now.
Okay.
Okay, so I'm sure you'll agree with me, a catalogue of errors in that short video clip. When you looked previously at Egon's theory and what was necessary in an effective communication scenario, there were three core competencies. That was acceptance, genuineness, and empathy. And neither of those core competencies were evident in that short video clip. In fact, it could be said that the nurse was on a different agenda to the lady who she was speaking to. She seemed rushed. She seemed totally disorganised. She was interrupted on a couple of occasions, one by a colleague, and then she actually took a mobile phone call during the consultation. Eye contact, non-verbals, all were not engaging with the lady, and therefore effectiveness of that short clip and that consultation was totally ineffective. So that's just examples of a very poor and inappropriate communication. Also, the fact that she had bits of notes stuck and post-it pads stuck to the notes could indicate indeed that there's a potential breach in confidentiality. Okay, so we'll look then at different types of inappropriate behaviour when we look at communication. I did mention briefly in the introduction about inappropriate language. This can be anything from the use of bad language, the use of abusive language, or indeed it can be where there is not a common language that's understood by those who are in fact communicating. And in cases like that, interpreters or another means, be it a family member, of communicating with those individuals is required, and that in fact is a legal requirement. Another way that messages can be misunderstood would be incongruent messages. In other words, when non-verbal communication and verbal communication are in conflict. And I have again a short video clip that demonstrates this quite nicely.
Since we've learned that nonverbal communication plays a huge part when talking to someone, it is important to match your verbal cues with your nonverbal cues. Hi, my name is Carmen Lugo, and I'm going to be talking about incongruent communication. Incongruent communication is when your verbal cues do not match your nonverbal cues. For example, I was at a festival this past weekend, and my best friend got sunstroke, and she was very sick. And I kept asking her, it was like I was like, do you want to come with me to the festival? Like, it's okay if you don't want to. And she was like, no, yeah, it's fine. I'll go. And the hesitation, the fact that she was shaking and I knew she was sick, I knew her nonverbal cues did not match her verbal cues. She didn't want to go in and she didn't want to tell me that. So I had to decide which cue I should pick up on. The fact that she was saying she wanted to go in with me, or the fact that she was actually feeling really awful and she knew it and it wouldn't have been good for her health. So to connect that, I took the nonverbal cue. I told her not to go in. She was shaking really bad, got really bad sunstroke. She still wanted to go in, but I wouldn't let her because she would have gotten way more sick. She ended up sleeping the rest of that day. And that's why nonverbal plays a huge part, because someone could be really up for something, but they could be really sick. And you got to pay attention to the body language and what they're saying, because if she would have gotten in with me, she would have probably gotten way more sick. So I'm really happy that I picked up on her nonverbal cues, and knowing my friend so well, I knew she was sick. And so that's incongruent communication, when your verbal cues don't match your nonverbal cues. Thank you.
Okay. So that is an incongruent messages and incongruent communication. An example of this from clinical practice I would use is in a first aid situation. If you are the first aider and you arrive on a scene where there are casualties, quite often the casualty who's shouting and screaming is not the casualty whose life is most in danger. It could well be the quiet casualty lying saying nothing, and I think that summarises incongruent messages quite well. Another way that communication can be inappropriate is through misinterpretation. Whilst we as service providers are maybe handing out information on a regular basis in the same clinical area and it becomes the norm for us, sometimes we forget that those service users this may be their first time in this clinical environment, and so it is all new, and information that we are giving them is very easily misinterpreted. An example of this I will give you. One of the tests, if you have hypertension or high blood pressure, one of the diagnostic tests that are used is a 24-hour tape recording is taking of your blood pressure. And in order to do that, a blood pressure cuff is placed on the arm and it is kept in place for 24 hours. What we would tell the service user who's undergoing this test is that this cuff will inflate and deflate every 15 minutes. And that happens, so that's 4 times an hour, and it is a 24-hour tape. The clue is in the name. So, what we also tell them is during the night this cuff will inflate and deflate, and sometimes it can disturb your sleep. But it is necessary to complete and to give a full picture so that a diagnosis can be made, and basically what the doctor who will report on this tape will be looking for is there any triggers that cause a rise or fall in blood pressure. However, what happens once this tape is completed? It's returned to the health centre, it's then interpreted. 10% of those tapes that are returned are inconclusive, and they're inconclusive because the tape has not been, or the cuff has not been worn for a 24-hour period. Even though we as service providers go through verbally the information of how the test is carried out, we actually give a leaflet with the equipment, and still 10% of the tapes returned have not been they're inconclusive and therefore have to be carried out again. So this is an example of how we as service providers may think we are giving very clear instruction and very clear messages, but it is not being interpreted correctly. And that can be for a number of reasons. And what we have to consider is, does the individual have the understanding or the ability to understand what information is being given to them? But that's misinterpretation. We'll now look at breach of confidentiality. I have a short video clip that gives you a really good example in the healthcare service of how
I've got someone from Sedgwick on
how
the phone
confidentiality
for
can
you.
be breached.
I'm sorry I didn't catch your name. She's online too.
Hello, Marilyn Perry.
Hello, this is Staff Nurse Hudson from Sedgwick General A&E. We're just admitting a Mrs. Dora Templeton, a patient of yours, and she seems a little confused about her medication. Can you just confirm exactly what she's currently on, especially the dosages?
Just bear with me and let me have a look. Sorry, our computer's really slow today for some reason. Oh, here we are. Warfarin 2 milligrams daily, coproximol 2 tabs PRN, atenolol 50 milligrams daily, bendrafluozide 2.5 milligrams daily. That's the lot.
Thanks a lot, that's a real help.
No problem.
Bye!
Bye.
Hello, East Collinwood Health Centre.
Hello, I'd like to find out the results of a test I had done at yours the week before last.
Okay, can I have your name and date of birth, please?
Nadia Croft, 12/4/89.
Okay, that's 65 Bedford Road,
Yes.
and it's about the chlamydia test.
Yes.
Okay, right, it looks like your test results have come back from the lab, Nadia, but I don't have the details here. I think it's best if you book an appointment with Dr. Turner. It looks like you need a review on your Marvelon anyway, so you might as well kill 2 birds with 1 stone. Would you like to fix an appointment now, or would you need to check with someone first?
No, I can make the appointment.
Okay, Friday at 3?
No, I don't get out till 3:30.
Right, 4 then?
Okay.
Okay, let me just put that in. So that's Nadia Croft, 4 o'clock, Dr. Turner. That's done? Okay then, bye.
Bye.
Okay, so if we review that video clip, there was 2 breaches of confidentiality. The first, when the lady was asked for information from a staff nurse at an A&E, she clicked on and gave the information very freely. First concern would be, did she check that the person who was asking was genuine? And the second and very crucial one is that she did not check the date of birth or the details of the patient who she was giving information on. And that is very critical, because in actual fact, wrong medication could have been given over. It may not have been the right identity to the patient. The second, the latter end of the clip, is the other breach in confidentiality was where a female's notes and address and name and test was discussed in a public area where other members of public were within earshot, and the information, to make it worse, was of a sensitive nature. So again, another breach of confidentiality, inappropriate behaviour. Okay, we'll also look then at a breach of trust, and an example of that would be where information has been disclosed on a need-to-know basis, and it has been carried out of that environment. In other words, the people who needed to know that information are not there, and the information has been taken out to another group of people. For example, if you are looking after someone in the care environment in a ward of a hospital, and you go then to a public place, meet your friend and have coffee and discuss some of that information, it's not only a breach in confidentiality, but there's also a breach in trust there. Okay, so other inappropriate behaviour in our healthcare environment could be an invasion of privacy. Take, for example, if you're in a nursing home and you need to go and deliver some care to a service user who is in the room, then it's common courtesy to knock on the door and give them that respect. They are, for all intents and purposes, that home is now their home, and you're a guest in their room. Therefore, we must be mindful to respect individuals' privacy. Other inappropriate behaviour can include the misuse of power, and that could be something like bullying. It could also be threats or abuse, and I have a very good little article here that has just been launched this year in the Belfast Trust, actually, from the Health Board, and this looks at the incidence of abuse, and it's really launching a zero tolerance to abusive behaviour. And this was launched by Joe Brogan, who is he's a pharmacist, the head pharmacist in the Health Board in Northern Ireland. And basically I'm going to quote from him when he states in this article, "In the last 6 months we have seen a number of attempted thefts, some of which were involve violence or threats of violence to community pharmacists." He also states that it will not be tolerated. Abuse towards any member of staff should never be tolerated, and we want to raise awareness of the abuse that is directed towards our staff, particularly those in primary care settings such as community pharmacies, GP surgeries, dental clinics, and also opticians. And this is their launch of a zero tolerance, which is indicative of the fact that there is this type of threats, abusive behaviour, even theft within our health service. Another type of inappropriate behaviour in healthcare would be prejudice, stereotyping and values and beliefs. Now, you will know from your first assignment in your professional and personal development unit, where we looked at values and prejudice. We all have values and we all have prejudice. However, when we enter into the arena of healthcare and social care, we need to leave those at the door. We also need to be mindful that other people, i.e. service users, will also have their own values, their own beliefs. They may have prejudice and they may stereotype. But we need to be mindful that we treat everyone as an individual and our own values and beliefs are set aside. Okay, So we could encounter inappropriate communication every day in our environment. So we can react to it in many different ways. We may ignore it, or we may actually react to it, where you have a confrontational situation, as we see down here in the bottom. Or indeed, we can re-educate and learn from this inappropriate communication and make communication better. So, types of inappropriate communication, we've talked briefly on this. It may be personal, it may be aggressive, it may be verbal abuse, there may simply be misunderstandings. I've also talked about the social barriers, which could be cultural, there could be language, there could be a disability, or indeed what we haven't touched on is there could be effects of substance abuse, such as alcohol or drugs, or indeed an underlying illness. And then professional, we've looked at that, the use of breach of confidentiality. We've looked at stereotyping, we've looked at conflicting messages and congruent communication. What we also haven't chatted about is the use of jargon, and I think we're all very guilty as professionals of using jargon. I mean, to me, an AMSSU is a common abbreviation I would make for a midstream specimen of urine. To somebody coming in and asking them if you can collect an AMSSU or a midstream specimen of urine can be terribly, terribly confusing. It may mean nothing at all. And I usually liken that to the skit for Mrs. Brown's Boys. When she was asked for a midstream specimen of urine, she envisaged herself in the middle of a river trying to pass urine. So we're all guilty of using jargon. Simple things such as, I'm going to take your BP. That's fine, we all know that's blood pressure. But to some older person or someone maybe with learning difficulty, they may not have any idea what you're talking about. And interprofessional use of jargon is very common as well, so we need to be mindful of that and just break things down into small chunks where they are understandable for our service user. Another example of that can be in the ward round. Doctor comes round, gives a load of information, maybe test results, to a service user, asks if they understand that fine, and they nod their head and say yeah, and then we as nurses have to come along behind and explain exactly what is going on because they just haven't a clue. Okay, non-verbal communication and aggression. I've just that one in just to make us aware of non-verbal aggression as well. Okay, so why can staff communicate inappropriately? It may be because they have had inadequate or a lack of training. They may not even be aware what is appropriate. They may not be supervised or developed as such. They may have disregard for professional roles or their superiors, or just a sheer lack of respect for those service users. This is quite a disturbing clip that I'm going to show you. You've probably come across it before, but it's a clip taken from the BBC News looking at the Winterbourne care home. Now, Winterbourne care home was a facility in Bristol that was designed and a state-of-the-art facility for individuals with learning disability. And Winterbourne was closed down, and rightly so, for a litany of inappropriate behaviours. This is disturbing, so I'll warn you now.
The corridors of Winterbourne View Hospital for People with Learning Disabilities are now stripped bare. But it was here that a hidden BBC Panorama camera filmed the most appalling abuse of vulnerable patients. It cost authorities £3,500 a week to send a patient to this private hospital, but today's report describes a place of arbitrary violence where restraint was commonplace. The 11 members of staff who've admitted the ill treatment and neglect of patients are awaiting sentence. Wendy Fianda's daughter Kirsty was at Winterbourne View. She has been shocked by what happened there.
Horrified, absolutely horrified. You listen to what she'd said to me over time, and it just made me think that each time that I'd spoken to the manager and questioned things she'd said, I'd always been given a logical answer. And then you start asking, why didn't I take it further?
Today's serious case review is damning. It shows that Winterbourne patients went to accident and emergency 76 times in 3 years. The local council received 38 safeguarding alerts, but little was done. The report concludes Castlebeck, the private company that owned the hospital, took financial rewards without any apparent accountability. And this left vulnerable adults in the hands of poorly trained and poorly supervised staff.
We cannot put people together in hospitals and leave them without any credible monitoring and the naive belief that this hospital can deliver both assessment and treatment.
The councils and health authorities who sent patients here are said to have had an out-of-sight, out-of-mind attitude. They say they'll learn. And in a statement, the owners Castlebeck maintain they've made significant changes to ensure there can't be another Winterbourne View. Terry Bryan is the nurse who blew the whistle on what was happening there. He now acts as an independent inspector, but says abuse remains difficult to detect.
People can hurt people if they want to. And if they want to, they will, because they'll do it behind a closed door when no one's looking.
Winterbourne View was closed down more than a year ago, but for many it leaves the question of how such a place, which was large, locked and cut off from the community, could ever have been the right place for people with learning disabilities. Alison Holt, BBC News, South Gloucestershire.
Okay, quite a disturbing video clip there, but summarises total inappropriate behaviour, in fact serious consequences, and rightly so, for all involved. Okay, we're going to look now at why inappropriate behaviour might occur from a service user, and that may be because of an underlying medical condition. And that may be that perhaps they have a high temperature, which could leave them disorientated, and indeed can in some cases cause aggressive behaviour or inappropriate communication. There also may be a learning disability there where they are unable to communicate verbally or non-verbally. They may be afraid. They may be hungry. They may be alone, bored or frustrated. An example of this might be if you take an older service user maybe who has lived independently, maybe with their partner, lost their partner, and then can no longer function by themselves and may have to go into a care home. And quite often in a care home they can spend quite a bit of time by themselves in the room when they're not in the day room with others, and that can leave them quite frustrated. And this sometimes can manifest itself in those service users maybe pushing the buzzer, looking for attention. And still, if we understand that this is all just part of the process of them coming into the huge change in environment that they've had to deal with. Also, if we are not taught how to communicate effectively, or there's a lack of role models in growing up, then that can mean that inappropriate behaviour is satisfactory. It could even be the environment. If we look back to Winterbourne, that was occurring over a number of years. When you see the number of A&E visits, those inappropriate behaviours were reoccurrent, which would indicate that they were acceptable. And sometimes if something is accepted, no matter how bad it is repeated, and that becomes the norm. So the environment has quite a bit to do with it. I'm going to now just clip on to this video tube here. Couldn't find the mouse, my apologies.
All sorts of professionals such as psychologists, psychiatrists, criminologists and sociologists have written about violence and aggression, and many different theories offer explanations as to what causes a person to present such behaviour. It would be dangerous practice to follow just one such theory. The care worker's role is to look at the individual person and try to understand their behaviour. A care worker is not expected to develop in-depth knowledge regarding all the different theories which exist, but what they can do is to try and understand more about the service user they're working with. It takes time to find out about past life experiences and how the service user feels about them now.
I tried to take my
Very often, a person has unresolved feelings about something which happened a long time ago, or is carrying resentment towards someone.
This one nurse would hit me with a towel hard and forcing me into the bath and laughing while he did it.
Let's now look at the different types of behaviour. Reflex behaviour. The person cannot control their behaviour. This behaviour can communicate to a care worker a great deal about the service user's physical or emotional state.
Don't be so stupid.
Who are you calling stupid?
Reactive behaviour. The person has some control over this behaviour.
Start smelling, don't you?
Oh, no. Go away! Go away!
Intentional behaviour. The person has control and conveys meaning to someone else. Let's look at some examples of challenging behaviour and some possible root causes behind the behaviours. Some people believe that people are born aggressive or violent. That is, it's innate or genetic.
Some people just can't help their nature, I guess.
Kerry, I don't know any Kerry.
Oh, of course you do, Mary.
Medical conditions such as Alzheimer's disease can sometimes cause changes in behaviour which can be very stressful for family members.
In recent years, she started shouting and swearing at people, and frequently talks in an uninhibited way.
Morning.
Sheer frustration can cause a person to vent their anger through their actions. Having a physical disability, such as suffering a stroke and losing power of speech, can be very frustrating, especially when a service user cannot do things for themselves or fails to express their needs.
Sorry?
Aggression can also be brought out by the way others behave. For example, when a service user is aggressive or hostile in some way, the care worker may feel aggression building up in themselves as well.
Look, you're beginning to aggravate her. You better go.
Oh, fair enough.
Some service users, when they have used aggressive behaviour in the past, may have got their own way because people have given in to them. So negative behaviour has reaped rewards or got attention. Care staff need to be careful not to fall into the same pattern of response. A controlling person can continue to treat staff the same way they've treated their spouse, close relatives or friends.
I don't want to calm down! Ow. And do it quicker next time.
The onset of aggressive behaviour can be brought on by a change in medication, use of drugs or alcohol, or someone may be experiencing a chemical change within their body. For example, hormonal imbalance. Past history is very important in explaining behaviour.
It's just that I get so angry when I think of all those years being locked away. It makes me want to smash things up.
It is equally important for care staff to be conscious of and analyse their own behaviour. We need to be aware that a care worker can trigger off a violent response from a service user by the way they act. They should therefore watch the body movements of a service user, such as jerky hand movements, to see if they're responding negatively to them. Pointing at a service user. Shaking an object at a care worker.
You better go.
Getting too close. Tightening facial muscles. Clenching fist. Pacing round room.
You'll get it, or I'll give you a slap.
Okay, so a summary of challenging behaviour and just give you a wee bit of insight how to deal with it and why, from a service user's perspective, that it can occur. So how do we respond effectively to inappropriate communication? Well, inappropriate behaviour. The first thing we will refer to is, as a health and social care practitioner, we must act professionally, mindful of our professional values. Okay, so our values are stated in the standards of practice for the health and social care workers. So NISC set out what our I don't know if this is going to open, what these standards are, and we as service providers must abide by those. That's not opening, but on the DLE you have got the NISC standards of practice, and indeed the NMC, the Nursing and Midwifery Council ones, are on the DLE as well. Just to take, when we look specifically at communication, what our requirements are, and the NISC standards state that we should listen well and communicate clearly, and similarly communicate with service users and carers and involve them in plans in their care. So it is a legal requirement that we communicate appropriately with our service users. Indeed, and our policies will state that, as will our code of practice, but so also will legislation. So our Equality Act states that everyone must have equal opportunity. Our Human Rights Act, where they must be treated as an individual and indeed deserve to be. The Data Protection Act, which will be updated actually this year, in May of this year, taking into consideration Brexit. There will be an update in May of this year, but at the minute it's the Data Protection Act, whereby we legally must look after patient information. As we saw in the video about the breach of confidentiality, that would be illegal on our part, and indeed there would be consequences for that. And also, out of the legislation comes our local policy, and we all work in different areas, but there will be a policy on confidentiality, on safeguarding equal opportunity, and anti-bullying, and many, many other policies that come out of these legislations. What we also need to do is understand why this inappropriate behaviour occurs, and see if we can assist assist the service user and address it and change it. So we need to ask the following questions. Is this the first occasion, or is this an isolated occasion, or is it occurring repeatedly? As we saw in Winterburn, it was occurring repeatedly. Is it one person or more? Are there environmental factors to consider? In other words, in Winterburn, this aggressive and abusive behaviour was considered the norm, it would appear. And what is the impact or likely impact on others? All questions we need to ask. So when we've ascertained why the inappropriate communication is occurring, then that will guide us as to what strategies we need to put in place to manage it or to respond to it. So that could be training for a group of people or one person. Environmental changes. Does something within the environment need to change? Does it require disciplinary action? As we saw from Winterburn, the individuals concerned were suspended and then laterally removed off the register, so were no longer able to practice. And we also need to raise awareness across groups of people and change the attitude. So if initial supportive methods do not affect change, then more severe punitive measures will indeed be utilised. So if we look sort of preemptive ways of improving practice, it could be something as simple as staff training, really assessing needs, promoting rights, going back to our care value base. Also some training, and I have put a link here to the NAPI training. NAPI is the guy who wrote this training, and this is a lot of environments where they deal with service users with challenging behaviour go through this. You can have a wee read at that later. This is all a well-known training package on how to deal with challenging behaviours. Oops, sorry, that was the NISC one that did eventually load up there. Okay, so that can be preemptive and how we can deal with challenging behaviour. We also need to be able to react should we come across inappropriate behaviour, and that can be that we can be assertive, we can use appropriate body language, not holding the hairbrush up, which could have been in that video a trigger, trying to diffuse aggression. In an appropriate environment, what do I mean by that? You're not going to leave yourself vulnerable in an A&E, for example, where you may have service users coming in where there may be substance abuse. You're not going to be in that scenario by yourself. You are going to have a backup. There will be a policy if an event breaks out, how it's coped with. We looked briefly at the whistleblowing when it came to Winterborn. That is a policy whereby if you feel behaviour is inappropriate, you will be safeguarded in reporting that and it will be investigated. Winterborn became or was investigated and became in the public and was in the public domain simply because of a whistleblower who we saw as later an inspector, but his identity was protected. A full investigation was carried out, and that was exposed, and obviously that behaviour could no longer, and rightly so, occur. Disciplinary action will be carried out, and the bottom line is you will lose your right to practice if it is proven by the council that you have been behaving inappropriately. And if you want to look on the NMC or the NISC website, you will be actually able to see cases, current cases, and that's not only in the UK, it's in Northern Ireland as well. You're able to look into those cases and see incidences of inappropriate behaviour, and unfortunately it is all too common in health and social care in Northern Ireland. Okay. When we strip communication right back, I'm going to bring you back to the Egan 5 key components of active listening or any effective communication. And this reference, you've looked at this before when we look at communication. But the SOLAR acronym, which means when we are communicating with someone, this is very simple. Strip it right back, go back to basics. When you are sitting chatting to someone or talking to someone, sit straight. It's important that, and particularly if you have visually impaired or communication issues, that I am here with you. So sit up straight in front of them so that they can see you. A good open posture indicates that you are willing to listen, and you're also to anything that the speaker will share with you. Lean forward to show that you're listening, that you're expressing an interest in what is being said. And use eye contact. This is another way of expressing interest and reassurance. And relax. A relaxed posture puts your speaker at ease. So it's really, when we look at inappropriate behaviours, strip it back to basic. Think about the last chat you had with one of your service users. Were these five key components present, and were you actively listening? Okay, for those, and I know we've looked at communication difficulties and what we can put in place to help support those in your last assignment. I have just put an article here on the loop system for individuals with hearing difficulties. The loop system, it's just a written article on it. What is it? Basically, the loop system is a microphone system that allows individuals with hearing difficulties to hear what is going on in public places. So you'll see them installed in the like of the Grand Opera House or in churches, and that's just another type of assistive technology that is available so that communication is appropriate for everyone, including those who have hearing difficulties. Also, again, the use of advocates, translators, interpreters, signers should be made. In fact, it's a legal requirement that we make these available. An advocate is a person who acts on behalf of an individual who maybe is not able to communicate. That can be someone with learning difficulty, or it can be someone who maybe has had a stroke. Okay, I've given you some additional reading. That's me finished with the inappropriate behaviours in the communication unit. However, I would like just to leave you with an article that was published this week. It appeared in the Sunday Times last Sunday, and it's also in Monday's Daily Mail. And this is an extremely good account, and actually moving account, of how a doctor, an intensive care doctor, became a patient on her own ward after almost dying when she lost her unborn baby at 7 months. And she learnt a lesson about the relationship between staff and their patients. I'm going to click on this, but I'm going to summarise a few bits of it. So this lady was 7 months pregnant. She was out shopping. She went to her own A&E. She was extremely ill. She was hemorrhaging. Load up. And this is her experience of how Her colleagues dealt with her in the A&E department. This is a picture of her and her family. So she was in incredible pain. Now this lady had not taken any medication. She was trying to avoid medication during her pregnancy, but she just felt very bloated. She was bleeding, and she was admitted to the hospital. The first thing they did was they gave her an IV infusion of controlled drugs, of narcotics, which she had never had those all through her pregnancy. Then they took her to the scan room, a very new, they're telling that, given me morphine. We almost never give morphine to pregnant women, and never mind heavy doses, because it would put her baby at risk. Then she goes on to eventually get the length of the scan room, and when she gets to the scan room, the junior doctor, who's very new at taking the scan, said, "Bear with me," and he'd actually tripped over the lead of the apparatus. He started to scan her, and she saw the picture of the scan. She said, he had said he wasn't great at interpreting scans, and she said, "You don't need to," because there she saw it in front of her eyes. The heart was still, and it was pulseless. And she just said, "There's no heartbeat." To which he responded, "Can you show me where you see that?" She was in shock with all the pain, but he couldn't even interpret that. Then they went on, she went through various processes, and then eventually a nurse, as she's getting iller and iller, she can hear her colleagues saying, "We're losing her. Guys, she's circling the drain." What she wanted to say to them was, "I can actually hear you," but she was struggling to maintain consciousness and couldn't let them know that she heard every word that they were saying. Then as she went into ICU, and when she came back round, she remembers a nurse being there saying to her, "Do you want to see your baby?" And she said no. She remembers seeing it motionless on the scan. And the nurse said to her, "Well, I think that's really sad." And then she started to go on to say, "Well, you don't get another chance. I don't want to be too graphic, but after a few days, their skin, it starts to break down, so you won't be able to change your mind." So this doctor is reflecting on all of this. This is, this nurse who said that to her had very genuine reason, I'm sure, for saying it. However, think of that mother, the mother of that dead baby, and the way that she has totally inappropriately addressed the subject. Anyway, on a lighter note, this doctor goes on to recover well and go back into her work, but she has learned very valuable lessons, and some of those lessons she quotes down here, that you're just a number, you are a disease. Doctors think of you as a disorder. They don't look at the person, in many cases, behind this array of symptoms, and she vowed that she would never let that occur again. So 6 months later, she described she was working in ICU, and there was a person there, actually there was a lady there who was in the same situation as she had been some years previous, and she went to that person once this lady too lost her baby. But one of the things she said to her was, "What are you calling your baby?" So that the baby's name is Charlotte, so that you're not talking about something, it is a little person. The other thing she reflects in this article, and I would urge you to read it because it is a very moving article, is she was nursing another gentleman in ICU, in intensive care, and there's me and my jargon and abbreviations again. Did it without even thinking. A good example of what you don't do. So in the intensive care unit, and this was an unconscious gentleman, and she reached over and whispered into his ear, "You are responding very well to the antibiotics." The man was unconscious to all intents and purposes. There was no reason to do that, but she had the full understanding that your hearing is the last sense that you lose. So that's my parting thought to you. A very moving article. I urge you to read it. Thank you for listening to me. Goodbye.